All right, we are grateful that we can continue on and to discuss new treatment strategies for metastatic RCC. I present Dr. Quan. Come right on.
Great. Thank you so much. Thank you, Pastor, very much. I'd like to thank the organizers. I'd like to thank the foundation. I'd like to thank Mr. Nicholson. I'd like to thank Dean Haley, who asked me also to, might I be available to be here. And it's really very much a privilege to be here to talk to you today about some things that really do matter so very much. And in a few minutes, we'll talk a lot about the subject of heroes. But let me just say that if you are somebody who has kidney cancer or has gone through treatment for kidney cancer, you are a hero. If you are a caregiver for somebody who has kidney cancer or went through kidney cancer in the past, you are a hero. And let's not forget, the things that, we like to see heroes on the screen and heroes on television and heroes at Super Bowl, but you know what you do matters. And so thank you so much for being here, and we're happy to be part of this day today. Okay, well that's me, and since I work for the University of Florida, I'm supposed to tell you that I do not have any relevant financial relationships with any commercial interests that would play a role in this talk. All right, so new treatment strategies for metastatic renal cell cancer. So usually what happens is that when we do talks of a different sort, usually for the physician-oriented talks, our part comes towards the end. And in the old days, we would have to do this talk in a different kind of fashion. But fortunately, this is an example of the following. So this is Sir Winston Churchill, who after one of the early Allied victories in 1942, following the Second Battle of El Alamein, said that now this is not the end. It is not even the beginning of the end, but is perhaps the end of the beginning. And in some ways, when you look at kidney cancer trials, we talk about maybe now we're at the end of the beginning. What do I mean? Well, this is 1987. Dr. Wright had this statement in terms of what about chemotherapy, like the drugs used for breast cancer, lung cancer, and colon cancer, and lymphoma or leukemia. What do they do? More than 50 different chemotherapy drugs used to treat those cancers. What Dr. Wright did was the following. This is what, if you know anybody or treat people or have been through the treatment for any of the most common solid tumors like breast and lung, even leukemia and lymphoma, the drugs that have been known to work do not work in kidney cancer. And so if you follow this right-hand column, what percentage of patients have their cancer shrink to really the measurable degree, and you get basically about 5% when you add everything together. And so up through the 1980s, it was bad news if you had kidney cancer that was widely spread. And so what we call phase 2 trials, meaning when you combine all the new treatments, looking at chemotherapy and looking at response rate, in other words, the percentage of patients that had their volume of tumor, their tumor size, in other words, decrease to really the levels that we measure statistically between Dr. Yagoda's study and Dr. Gitlitz's paper in 2001, 5.6% of patients had cancer shrink. And the reason is that kidney cancer has the ability to have what we would say as physicians drug resistance. What does that mean? In other words, kidney cancer has high levels of a substance, a P-glycoprotein, which acts like a pump. So when the kidney cancer cell is exposed to the chemotherapy, it pumps the chemotherapy out of its system or out of the cell, so it is unharmed. So it's impervious to all the drugs that act like the common breast cancer treatment drug, Adriamycin. it is resistant to the breast cancer and lung cancer drug paclitaxel or Taxol. And it's very much resistant also to the higher amounts of chemotherapy that we give to people for stem cell transplant, those kind of chemotherapy agents that are called alkylating agents, because kidney cancer also has a special kind of enzyme, a special protein called glutathione that goes and essentially repairs any damage that an alkylating agent would make. And so it was very dire news in the 1980s. And I should say about, when we talk about, and I say now, the young people that I teach now, none of whom were around in the 1980s. And so we say, well, 1987. I remember 1987 very well, okay? So that was only 10 years after Star Wars was released in theaters. And I say, Dr. Quan, you saw Star Wars in the theater? Yeah, I did. I remember it. It was great. They said, oh, you must be old like Yoda. This is what we get every time. But if you remember, and then soon after that, okay, this is the Godzilla film. I mean, the Godzilla film that had Matthew Broderick in it, okay? And in it, there's the line where the Army officer, looking at the massive creature through his binoculars, says, I have to get me a bigger gun, okay? And that's how you felt late 1980s, okay, for treating people with kidney cancer and into the 90s. Because there's a principle of relativity. In your mind, if you think of what's a kidney, what does a cancer cell look like in terms of relative size? Okay, microscopically, then a cancer cell like kidney cancer is the size of a grizzly bear. The white blood cells or immune cells that we hope to be able to use against the grizzly bear is the size of an attack dog. So it's bear to dog kind of a size. But we know that a pack of dogs, properly motivated and high enough in number, can bring down a grizzly bear. We know that a group of hyenas can kill a lion. And we know that dolphins swimming at speed in large enough numbers are able to kill sharks. And so it's a principle that has been applied. And so this is the model that came about from the late 1980s and into the 90s of a cancer cell being swarmed over by specific white blood cells that are called natural killer cells. Now, the natural killer cells are white blood cells or immune cells whose major function primarily has been to act as kind of surveillance, to protect us from some things that don't belong in our body, but their numbers are very small. And so there was hope that if there might be a way, and we'll go through this diagram kind of as progress has been made in terms of the treatment for kidney cancer, there might be a way to use some element of the immune system. And during the 1980s and 1990s, so sort of the gold standard or the major hope was that a certain kind of white blood cell, not the natural killer cell, but the T cell, the one that protects us and has the highest numbers in terms of rejecting things and killing things that don't belong in the body. If there could only be a way that T cells, in other words, when a child has a vaccine or gets a vaccination, you develop an immune response or the ability to make an immune response so that if that child is ever exposed to that kind of infection for real, that child's immune system will kill it. And the hope had been, could there be a way somehow that the immune system could be stimulated, educated, and prepared to kill cancer cells? Now, we should say also, too, that when you think of how much cancer is in the body of a person with widely spread kidney cancer, and you look at animal models that say, so this is about a centimeter, say this is about 100 million cancer cells fit in this amount of cancer. And you say, oh, goodness, most of my patients don't have this amount of cancer. They have things that are this big, and multiple ones. And so you say, oh my goodness, how many billion cancer cells might my loved one have? And if you say, well, one attack dog cannot kill one grizzly bear, but maybe you need a pack, then you start to say, oh my goodness, how big of an immune response has to happen for something important, something wonderful to occur. So in the 1980s then arose a substance, a protein called interferon, that we naturally make in only small amounts, but because of genetic engineering, physicians were able to give patients interferon. And interferon is an inducer, in other words, a stimulator of natural killer cells. And Dr. Gore, looking at 458 patients in this large clinical trial, found that 73 patients, or 16%, had their cancer shrink by at least half, and 11 patients, or 2%, had disappearance of all cancer. Now, the numbers are small, but at the time, compared to 5, we prefer the 16. The 2%, that's not what we'd love to have, but it's better than the 0 that was seen up to that point. So it gave some ray of hope. And I will also say that if your loved one's one of the 11, then it's not a 2% drug, it's a 100% drug. And that's why when we talk about cancers, the treatments that are able to give any complete remissions, meaning the doctors just can't find anything more on the CAT scan ever again, it really does matter a lot. And I think that in the end, that's where we have to have as our goal. Okay. All right. So this is Dr. Stephen Rosenberg from the National Cancer Institute. And Dr. Rosenberg looked and has worked a career at trying to find this kind of T cell, this specific cancer killer, taking it from the person, growing it in the laboratory in large enough numbers and giving those tumors, those killer T cells back, or trying to find these other attack proteins, maybe better than interferon, to stimulate T cells in a person's body. And what happened is that Dr. Rosenberg found that a specific protein that acted maybe not so much on T lymphocytes or T cells, but actually stimulated natural killer cells to become sort of activated natural killer cells or supernatural killer cells or lax cells. He discovered or used this protein called interleukin-2 in people. And this has become, in a genetically engineered form, the medicine that arose in the late 1980s, and it was approved by the U.S. Food and Drug Administration in 1992 as the first kidney cancer treatment for widespread kidney cancer. And so this messenger attack protein that converts natural killer cells into supernatural killer cells or lymphokine activated killer cells or lax cells. And Dr. Rosenberg, along with Dr. Fisher, 255 patients treated, 37 patients had their cancer shrink by at least half, so 15%, but very importantly, 15 patients, or 7% of patients, had their cancer disappear altogether. And there are patients from this 1999 study that remain in complete remission to this day. And so, for once, specific patients free of cancer, widely spread, for whom there was no other treatment available. And so that gives us hope. However, there is a downside, okay? Flu-like symptoms, well, maybe that's not so bad, although it's still kind of tough to have the flu, if you think about it. But low blood pressure, fluid retention, some patients having liver or kidney abnormalities, some patients ending up in intensive care units. And so this is a treatment then that had to be done in specialized centers. And so the majority of oncology physicians practicing today have never given this treatment because it's very hard to do. And you have to have a team to be able to do this kind of treatment. Because so much effort was being put into the immune system, and still the percentages not as high as we would like them to be, another type of therapy arose, and these are these molecular, targeted, or not chemotherapy in the traditional sense, but targeted therapy or growth factor blockers. So in other words, cancer grows because it likes to feed itself. It likes certain things that it uses for nutrition to grow, and these growth factors attach themselves to the cancer cell and gives specific targets that new drugs can be developed to act against. And so sunitinib was an example of a targeted therapy, and it was a pill. And so the popularity of this treatment arose and became really the standard treatment subsequently. An example was Dr. Motzer's study of 375 patients, both at Memorial Sloan Kettering and a number of centers also around the country. And 31% of patients had their cancer shrink. And in a head-to-head competition with interferon in that study, patients treated with sunitinib, the oral drug, this pill that patients would take, 31% of patients with sunitinib had their cancer shrink versus only 6% of interferon. And you said, well, wait a minute, I thought interferon gave higher numbers in another study. Well, this is like the Super Bowl. You said, well, the 49ers killed everybody, right? And then the Chiefs, they were beating everybody too. Well, who's the better team? And you say you have to have a head-to-head competition. And that's what we talk about in terms of a clinical trial, is this specific kind of, or phase 3 trial is the head-to-head or Super Bowl type competition. And in the Super Bowl, in this study, the pill was better than the interferon. And so this line of therapy arose as something that you commonly did. And so you developed then, or over time, there developed a whole family of pills that targeted these growth factors or prevented kidney cancer growth that one would typically use one after the other. Downside, not everybody or not even the majority of patients would have their cancer shrink. There's side effects: diarrhea, fatigue, nausea, vomiting, skin problems also too. And very few patients had their cancers disappear. And so then the thought had been, could it be to treat patients with kidney cancer with these pills one after the other to control kidney cancer? And so that's another possibility that was raised during this time. So kind of at this point, if you looked at kidney cancer up to about the year 2000 and into this century, it's like the Avenger movie, you know, when they're trying to work out time travel. And so you send the Stephen Lang character back and you bring him back and it's not quite right. And then finally at the end, very desperately, the Hulk character finds a way, jiggling the machine, and they bring him back. And he says, I see this as an absolute win. And at which point the Captain America character is, well, I don't know. I just don't think that we're where we need to be. And so just like in the movie, we needed to have a Tony Stark, somebody who at least figured out the first part. Because if you're gonna defeat Thanos, just like you're gonna say, if we can ever beat kidney cancer, we need to have a breakthrough, a game changer, something to at least kickstart the process. And for immune therapy for kidney cancer, our Tony Stark is Dr. James Allison. So based on work done in New York and in Houston, Dr. Allison was awarded the Nobel Prize in Medicine for what we're going to talk about next. So in general, I should say our immune system does not wish to harm normal cells. So CTLA4 and PD-1 these are abbreviations, and if I tell you, oh, it's cytotoxic T lymphocyte-associated protein number 4, you know, everybody else will sleep, right? But if you just say there are these checkpoints these special places that are on immune cells, that the immune cells will say, okay, I understand that I'm not supposed to touch, I'm not supposed to harm things that are normal to the body, okay? And those are what we call checkpoints on the immune cells, right? What Dr. Allison found is this, that if you could develop antibodies that block the checkpoints, okay? And one example of an antibody for the CTLA4 checkpoint is called Ebolaman. Another antibody for the PD-1 checkpoint is called Nivolumab. If you block the checkpoints, then the immune system is free to be able to kill cancer cells. Because the problem is that cancer cells often have, because they come from normal tissue originally, they have some of these false identifying marks that tell immune cells falsely to leave me alone because I'm here. In other words, it's like saying someone steals one of the hospital badges and can get around through all the different checkpoints to be able to say, I belong. And that's what cancer cells can have the ability to do, to avoid the immune system. And so what Dr. Allison found is that if you block the checkpoints, if you block PD-1 so that the cancer cell now is able to be seen by the immune system, then instead of using chemotherapy, instead of using targeted therapy, could the immune system be used to do some wonderful things? Okay. And so this is a clinical trial. In other words, when you talk about clinical trials, we talk about new treatment, and there are specific rules for clinical trials. Clinical trials are written so that we have a level playing field to be able to say groups of patients balanced in terms of do they actually have the cancer, how much cancer, and what part, and we can measure how much cancer. And the trials that we're going to talk about are ones where there's a balance between what was the standard therapy, and at that time, sunitinib, versus a combination of two of the antibodies used to stimulate the immune system, nivolumab plus ipilimumab. So against the defending champion in this competition, looking at 1,096 people with kidney cancer. Those that received nivolumab plus ipilimumab, 42% of these patients had their cancers shrink very measurably, versus sunitinib about 27%. And this number here just means what's the likelihood that this was a random event? In other words, meaning maybe did this happen just by accident? And you'd say, well, you get results like this with this kind of difference in less than 1 in 1,000 times. So if you ran the trial 1,000 times, you'd say, well, this would happen maybe once or not even one time. So you say it's a real event. In other words, it's like saying, I don't think the Chiefs are better than the 49ers. But if they played 1,000 times and the Chiefs win 999, I think most everybody, except a few people in San Francisco, would say, well, I guess they're better. Okay, but that's the equivalent. That's the equivalent of what that statistic means. But here's a key point. 9% of patients receiving the combination immunotherapy free of cancer. 1% in the sunitinib arm. Okay, a big difference. Side effects, fatigue, itching, diarrhea on the combination arm, diarrhea, fatigue, nausea on the pill form. And let me just say, the pill, think of, oh, it's got to be easy, right? It's just a pill. Not necessarily. It's not the form. In other words, you say, well, the linebacker's only 5'11" and 230 pounds, but gee, if you're Ray Lewis, oh my goodness, wow, he hits pretty hard for 5'11", 230, and say that little pill can be harder to take than all the stuff given through the IV. So, it's not the form, okay? All right, it's what's inside. Okay. How about another one? This is another antibody, okay? It's very similar to nivolumab. It comes from the same class. In other words, it's a PD-1 related antibody. It's like Pepsi to Coke, okay? So pembrolizumab plus axitinib. Now, axitinib is kind of a later model, a later addition, a later cousin. Some would think maybe even theoretically a little better than sunitinib. So a combination of an immunotherapy agent and a growth factor blocker versus the growth factor blocker. And Dr. Rini from the Cleveland Clinic looking at 861 patients. Pembrolizumab plus axitinib, more than half of patients had their cancer shrink. And so even though sunitinib did well, 36% of patients responded. Still a huge difference between these two numbers. And so you say in this Super Bowl competition, we say the immune therapy plus the growth factor inhibitor beats the growth factor inhibitor. And 6% of patients getting the combination free of cancer versus 2% on the growth factor arm. Side effects similar to what you see in some ways with the combination immune system, but also now, because you're using a growth factor blocker, you have some of the side effects of those pills. So diarrhea, hypertension, and fatigue. Sunitinib, kind of the same thing, diarrhea, high blood pressure, peeling of the skin on the palms and the soles. So similar in terms of certain things, but a big difference in terms of response rate, and a measurable difference also too between people free of cancer. All right. So then if you look at this model then, if we said, okay, natural killer cells, right? Perhaps the 1980s, early 1990s, into the late 1990s, a lot of work being done trying to see if the fewer number of immune cells could be boosted either number or in killing capability to kill cancer cells. And then finally, about 20 years later, progress being made with these blocking antibodies to stimulate the larger group of defensive cells that we have, the T cells, and getting them to be able to respond and to attack cancer cells has been kind of more of the theme. And so another treatment, a little bit different than the nivolumab and the pembrolizumab, the Ebolaman, and I'll show you, let me just go back for a second and say, if you block, okay, nivolumab and pembrolizumab are antibodies that block at this particular point, okay? You say, well, there are two ends to my charge cord, okay? You can block at the cord end, or you can block at the outlet end. And so an antibody developed to block at the outlet end, okay? Ebolaman was tested in combination with the growth factor blocker, axitinib. So the two A's together versus sunitinib, okay? 886 patients by Dr. Motzer, who, if you recall, did the study on sunitinib at the very beginning, all right? So 886 patients, the Ebolaman plus axitinib arm, more than half of the patients having their cancer shrink versus 26% in the sunitinib arm. Again, making this is a real effect. If you did the study 1,000 times, it's going to turn out this way, 999, basically speaking. And twice as many patients had cancer disappear in the combination. Side effects, diarrhea, hypertension or high blood pressure, fatigue on the combination arm, diarrhea, fatigue, nausea in the sunitinib arm. So what does all this mean? Well, really, this is what we're talking about. This is an example of a patient on an immunotherapy treatment, and I'm hoping it'll project a little better. All right, so this is a chest x-ray. And when you do a chest x-ray on a person, you have a light source that shoots through the person. And if you've ever had a chest x-ray, you stand in front of the film. The radiation goes through you and makes the picture, makes the impression. So this is the left side of this individual. This is the right side of the individual. This is the port that you give these kind of intravenous treatments through, okay? And this middle part, okay, this is you can see the darkest part is where his spine is. and this is his heart. Okay, and so when you put your hand over your heart on the left side, it's because your heart's on the left side. Okay, these dark areas, okay, are the lungs, and what you should see here is these little balls, well, not so little balls here and here and here and here and here, and on my screen here and here and here. So this gentleman treated with immunotherapy subsequently have every single one of these things disappear, okay? And this is the touchdown that we're looking for. And we're looking about, you know, we say it's the Avenger movie, this is what you want to see when you defeat Thanos. And so you say, well, what can we do? You know, where are we going? Is blocking antibodies, nivolumab, ipilimumab, pembrolizumab, avelumab. Is it the end of Thanos? Is it the end of kidney cancer? I'm not so sure we could say it's the end, but hopefully we can say it's the beginning of the end. But let me just say this, for every, you know, you see 1,000 patients, 800 patients, 500 patients, it's a clinical trial. If you remember the movie, okay, they said, you know what, we need somebody to go back in time and just see if the machine, the process works. Well, who's going to do it? And the Hawkeye, Clinton Barton character says, I'll do it. I'm game. For any of these studies to come to pass so the patients could receive results like this gentleman that I showed you, the chest x-ray of, somebody had to say, I'll do it. And that's where we have to go, is we have to find new treatments. Okay, we have to do better so that it's not just the end of the beginning anymore, but we move the bar, we get further along in the movie, because the movie was still, okay, Tony Stark discovered the secret, but a secret to a process that got halfway through the movie. We still got more of the movie to go, and Thanos is very big and very, very powerful, and there's stuff that we have to still accomplish. So hopefully we're going to find the Sherlock Holmes, okay, to put it all together so that we can get that going. And I'm hoping that which we're going to see next for our next speaker is kind of the next part of the movie to move the ball forward, to show, well, where are we going to go, okay? Not 1980s, not 1990s, not 2010, not even like the studies that I showed you from 2018 and 2019, but can we get to the end of the movie that we can go beyond where we were right now? Thank you so much. I appreciate the opportunity to be here. Thank you.